I'm so glad to be here with you all today. The title of my little chat for today is Setting Yourself Up for Success, Understanding Queer Relationship Dynamics from Preconception Through Parenting. Um, I, as you can probably tell from my voice, I'm a little bit sick today. I'm getting over a cold. So thanks for like bearing with me and the little sick voice that I've got. But I really was just excited to be here with you all today. Um, we can start with just some introductions of myself. I'm glad that you all have started to introduce yourselves in the chat. My name is Dr. Suzanne Mungales, but my clients often call me Dr. Zann. I am a licensed clinical psychologist and a certified perinatal therapist. I have a private practice based in Oakland, California, and virtually throughout California, called the Maternal and Mental Awareness Space, aka the Mama Space. Um, I'm also a childbirth educator, a lactation educator, and I've been trained as a doula. I am Black, Congolese American, and I'm queer. I am a woman, but I'm also gender expansive. My pronouns are she and they. And I'm a mother who has given birth. All of these identities just impact who I am and how I practice and how I show up in the world. So I wanted to name them for you. And one thing that I like to say is that in all of the work that I do, I am tender with people, tough on systems, and I'm relentlessly committed to our collective liberation. I also think that it is important to share um, that, like, in spaces like this, it's good to like just acknowledge some of my own insecurities. I think that a major part of the queer experience is constantly navigating either feeling too queer in some spaces or not queer enough in other spaces. And sometimes these feelings come up the most in like queer affinity spaces like these. So I am sharing that with you. Um, just sharing that, like, I'm holding that tension right now, even as I'm speaking with you here as a quote unquote expert. And I'm also sharing it with you so that I can break down some of this hierarchy, so that I can remind you that I'm human. And also to model something that I'm going to dive a little bit deeper into a little later. But that's vulnerability and naming the discomfort within relationships, especially when it comes to the differing queer experiences. So, with that, I will get into today's topics. Here's a little bit of an overview. Today, we're going to be talking about relationship dynamics and common challenges that we face as queer people during preconception, pregnancy, birth, and postpartum. But I'm also going to be discussing queer resiliency factors, like ways to prepare for and to get through some of these challenges. So before we start that, I want to also name two things. The first is that there's a wide range of identities within the queer umbrella. It's really impossible within just like an hour talk for me to speak to all of the identities. Throughout this talk, I'm going to be using the word queer as I'm talking about our experiences. But it's important to all just know that, I'm sure that you all know, but just want to name it, that the experience of a lesbian couple is different from the experience of like a bi femme and cis male couple, which is also different from the experience of like a T for T relationship or from a polycule or a poly parenting sort of relationship dynamic. So just want to be able to hold that. Um, the second thing I want to name is that I actually have a love-hate relationship with the word resilient. We, people who have been marginalized, we are resilient. That's true. We're strong. Um, but we're strong because we've been forced to be. We shouldn't have to be as resilient as we are. So I name that we're resilient, but I also am holding that there's a lot of baggage behind that word even. So I want us to keep that in mind also as I speak about our resiliency throughout this presentation. All right, so let's just set the stage a little bit. I often say that I'm a perinatal psychologist, but not everybody knows what like perinatal means or encompasses. When I say perinatal, I mean the full spectrum of from like trying to conceive to pregnancy to birth to postpartum, and even into pregnancy loss and birth trauma. For me, perinatal encompasses the time that precedes and follows a pregnancy. Um, and my understanding is that everybody in this group is at, different stages of this process. So some of us might have like more of an understanding of what goes into each stage. And for queer folks, what goes into navigating each stage also can look different from what it looks like for straight people. So what you see on the screen here is a non-exhaustive, certainly, but a list of all like the different stages of the perinatal period and what can go into that specifically for us. So looking at the preconception stage, again, it's not an exhaustive list, but what can go into it is like health monitoring, preconception counseling, different hormone therapies, assisted reproductive technologies, like IUI, IVF, etc. Then the pregnancy is 40 weeks, beginning at your last menstruation, and involves lots of prenatal appointments, dealing with medical staff, finding doulas and support people, and birth prep. Then there's childbirth, which includes early labor and active labor, the immediate postpartum. You're dealing with nursing staff, medical staff if you're in a hospital, different medical providers, and a lot of self-advocacy, which we'll talk about. And then postpartum. I tend to say that birth is a moment, but postpartum is forever. And within the postpartum stage, you're dealing with a new baby, sleep, infant feeding, a lot of dysphoria potentially, hormone fluctuations, co-parenting potentially, and even some legal support for some of us. So I'll start off by talking about some of the challenges that we face within each stage before we dive into how to navigate these challenges. And just a little bit of a spoiler alert, one of the first steps in navigating these challenges is to educate ourselves on what the challenges actually are, so that you know what to look out for, so that you can name them and work through them. And that's part of what we're doing here, in talking about the challenges first. Within each of these stages, there are challenges within the relationship dynamic, but also challenges within the system. And when I say system, I mean the medical system, but also like society as a whole. We hear a lot about this like cis hetero patriarchal system. That's the system that we're living in, and we'd be doing ourselves a disservice if we were to believe that what's happening outside of us and outside of our relationships don't impact our relationships. I feel like it's also important to name the challenges that the relationship is facing, because that impacts what's happening within the relationship itself. So for the preconception stage, there are several challenges that come up within the system. Having to engage in fertility discussions with healthcare providers, um, engaging with the medical system at all can be such a challenge to many of us. Also in the reproductive healthcare space, we don't always see ourselves represented. This becomes more true if you add like being trans to the mix, or if you add being a person of color, and the feeling of invisibility is impactful. Then, when it comes to making fertility decisions and discussing them with providers, we can be limited in what our options are. It's not always easy for us as queer folks to, say that we're not trying, the way that like straight people can just say, oh, well, we're not trying to have a baby. We can always say that. We have to be really intentional in our decision to have a baby. And sometimes even that in and of itself can be a challenge. And then we often have to experience coming out over and over and over again, whether that's to doctors or nurses or specialists, whoever it is that we're kind of working with as we prepare to even have a baby. That coming out process over and over again can be taxing. So then within the relationship, we're also having to navigate some really intentional conversations about fertility and fertility planning, from who wants to carry and when, to different fertility methods that feel accessible and feasible and even desirable to the person who is carrying, to discussions around finances. And then this is also a time where the differences either start to emerge within the relationship or are highlighted within the relationship. Like one person's body is starting to be thought of in a different way. Even if there had been some shared experiences of your bodies leading up till this point, things are starting to change. And there might be some feelings about that for both parties. So then moving into pregnancy and birth, I think that pregnancy and birth could be their own hour-long talk, but I'll try my best. Um, within the system, we know that there are many biases that exist. And during pregnancy, there are a lot of medical appointments, which means that there are many opportunities for those biases and oppressions to come about, with different medical professionals and providers. And then, there are so many experiences of what's known as obstetric violence. Obstetric violence is defined as like any form of violence or oppression or trauma, whether that's a physical trauma or emotional trauma that you experience from any of your obstetric or medical providers. And so that can range from like not being believed in a medical setting to being coerced into certain interventions, um, or for most of us, like not having our identities seen or acknowledged or respected. And then also our bodies do begin to change during this time. And so there might be some dysphoria that creeps in. And that dysphoria might not be understood by your providers or by society at large, or even by your partners. And then again, kind of similar to last time, just like the continued experience of having to come out over and over again, especially depending on where you end up giving birth. If you're at a hospital, sometimes you're having to come out to every provider that walks in the room, or every time there's a hospital shift change, right? These are experiences that are impactful to you as an individual and to the couple. And then within the relationship, there is often a change in support roles that kind of starts at this time. Even with the quote unquote like easiest pregnancies, the pregnant person does just require more, and then is unable to give the same amount in return. So there might start to feel like there's like this imbalance of support. And then some pregnancies are just more debilitating for various reasons. And then with those, one person often does become more of the caregiver, which then also shifts the relationship dynamic. And then intimacy will undoubtedly start to look different in pregnancy. For some, they experience a decrease in libido. For others, they experience like an increase in libido. So there like might be mismatched desires. Another example of like the ways that pregnancy impacts intimacy is that your idea of who or what is attractive to you might also be challenged. One example of this is you might be someone who is, has historically been more attracted to a more masc presenting person. And then suddenly your pregnant partner's body is changing. And it's changing in ways that make them look more like stereotypically feminized. And that might just like be hard to grapple with and reckon with. And they're actually real challenges to work through. Um, and then there are also very few support spaces for non-gestational parents to be. There are some out there for non-gestational parents in postpartum, there are lots of prenatal and centered pregnancy groups that are for the people who are pregnant, but there are very few support spaces for the non-gestational parents before they have their babies. Um, and so, as the non-birthing person is going through their own experience, they also need support, right? They also need support in supporting the pregnant person. Without these kinds of spaces, that support role can be pretty hard to hold. And then with that, the gap in understanding just continues to widen. It's really important for me to continue to name this gap in understanding that is widening, because that is the root of so many challenges in queer relationships in this perinatal period. And this is like, especially if you've been socialized similarly. So if you're both women or both femmes or have like similar transition experiences, um, there's a lot of beauty in that sameness. Like there's a lot of things that maybe you don't have to explain to your partner because they get it. They have similar lived experiences. But then that means that for a lot of people, pregnancy becomes one of the first times that there's like a real deviation from that sameness. And that can be hard for a lot of people to reckon with. So then within postpartum, there are a few different things to keep in mind. And I've actually separated the postpartum experience from the infant feeding experience, which will be on the next slide, because there's like a lot there too. Um, but within the system, there are a lot of societal expectations of what postpartum should look like. And a lot of it is geared towards a quote unquote mother. But then my question becomes, what if you don't identify as a mother first? Or what if you don't identify with what's called patriarchal motherhood, which is a type of motherhood that asks birthing people to do it all, to do it alone, to do it without complaining, and to enjoy every minute of it. That expectation weighs a lot on the individual and on the relationship. And then when you aren't able to enjoy every minute of it, when you experience any sort of postpartum mood and anxiety disorder, also known as PMADS, which I'll talk about in a future slide, the supports available are primarily not queer, or they're not queer centric, or not even queer friendly. So then within the relationship, there are role shifts that happen. One partner might be healing and feeding and might be the parent that feels more needed at that moment, while the other is taking care of other aspects of the house and caretaking. One partner might be preparing to go back to work outside of the home or in a paying job, while the other is at home doing the unpaid work of taking care of a child. And with that, then one partner might be taking on more of like the mental and emotional burden that comes with managing a house and planning and organizing and like anticipating needs, caring for the baby. That's a concept known as the mental load. While the other partner isn't necessarily as tasked with taking care of the mental load because they're tasked with taking care of, other things. And like one thing, because of all of this, one thing that I hear from clients a lot is, it feels like we're het now. Like it's just surprising to people that their relationship dynamics start to mimic a straight relationship. And that sometimes it's the first time that it's ever done that. It's like where the birthing person or the birthing partner is suddenly the stay-at-home parent, kind of begging their partner to understand their experience. And then the non-birthing partner is at work, providing financially or, not as involved in the ways that the birthing partner would want or need, but involved in a different way. And this shift in dynamic really tends to catch people off guard, especially if you have always prided your relationship on being so antithetical to your typical cis het relationship. So that's just like something that can surprise people. And I think that's something that we should keep in mind as we move forward in this process. And kind of similar to some of the other slides we've already kind of touched on, queer infant feeding can probably be its own presentation. Um, but I wanted to just discuss some of the relationship challenges that come up here too. Within the system, there are a lot of expectations when it comes to how to feed a baby. Um, there's this constant refrain that we hear all the time that quote unquote breast is best. Um, and there are lots of reasons that this phrase exists. Um, but it also doesn't take into account the challenges with lactation, top surgery experiences, or dysphoria that comes with lactation. Also, not many providers are well versed in what lactation can look like in a queer or trans or non-binary body. Like the words that they use and the images that they use might not be appropriate for you or might even be harmful to you. And then within the relationship, if one person is lactating and the other one isn't, there may just be a baseline inequitable distribution of labor. That's just kind of like the fact of it. And that's also hard. It's just like hard to deal with there being that sort of like inequity within the labor distribution in a relationship. And so it takes a lot of intention to be able to navigate that. There may also be a new relationship with your body parts. Um, for those who, have previously not really liked their chest area, they may find new meaning in these body parts. Or for those who have loved their chests or felt neutral about them, there might start to be the opposite, like a feeling of overstimulation or feeling touched out when it comes to these parts. It might impact your intimacy and like how you want to be touched by your partners. So then, kind of like with the previous sort of slides, the gap in understanding begins to widen even more. And there may be some feelings, from the non-gestational partner of like feeling helpless, like not able to do anything to really take some of these struggles and challenges away. And then the gap widens for the birthing partner because then they may start to feel isolated or alone in some of their experiences. So this is just a quick little run through of perinatal mood and anxiety disorders, which I kind of talked about earlier. I shared that, I'm a perinatal psychologist, so of course I need to drop a slide about mental health in here. Um, I think that, this is really important to talk about because these can occur during pregnancy or postpartum, and sometimes even following a pregnancy loss. Um, a quick little plug on my website, which I'll link to at the end of this presentation. I do have a free checklist for symptoms of perinatal mood and anxiety disorders, so that you know what symptoms to look out for, so that you and your loved ones, your family members also know what to look out for. So I'll make sure that you're able to get access to that. But I really want to bring up PMADs because people who've experienced any sort of mood or anxiety disorder throughout their lives are more at risk of experiencing them perinatally. And something that we know is that mood and anxiety disorders are prevalent in marginalized communities, including queer communities. So we just have to be extra on alert if we've experienced them at any point in our lives before. And it's not just the birthing person that needs to be on alert. Non-gestational partners are often the first people who are able to notice the signs and symptoms. So it's important for them to be on alert also. And then also, non-gestational partners can experience PMADs too. So it's important for them to not just be on alert for their partners, but also for themselves, because it's also possible to get pre or postpartum depression or anxiety or any of these disorders as a non-gestational parent.
You want a hug?
Well, that was actually maybe a good little pause because we've talked about a lot of challenges, right? And so I want to just be able to kind of like breathe into those for a second and um, yeah, just kind of like sit with what that sort of brings up as I start to talk a little bit about intersectionality, which is kind of like the last little piece before I start going into like the resiliency factors and ways to work through some of these challenges. Um, when talking about any of the challenges that we've discussed so far, intersectionality needs to be considered. And intersectionality is basically the overlap of our various identities and how they interact with one another. Um, when it comes to who we are in our relationships, we don't exist in a vacuum. We bring all of our identities and all of our experiences over the course of our lifetimes with us into our relationships. So then that means that how we speak to each other, how we hear each other, how we perceive things, and how we interpret things, those are all impacted and influenced by our intersecting identities and experiences. So, of course, our perinatal experiences and the challenges and how we work through them, they're all impacted by these intersecting identities that are at play within the relationship. So, again, this is like a very non exhaustive list of the different identities that intersect with our queerness and then impact who we are and how we show up in the relationship. Our race, ethnicity, nationality, citizenship, immigration history, our perceived race, our language, ability, class, mental health, age, education, and employment, our gender, our perceived gender, our assigned sex at birth, our sexuality, our perceived sexuality, our trauma history, parenting status, relationship status, incarceration history, and much, much, much more, right? Those all impact who we are and how we show up in all of our relationships. So, like I said, we just talked about a lot of the challenges, a lot of things that we face, a lot of things we already know. And that can be hard to hold. But as I also said earlier, we are resilient. Um, like I said, we shouldn't have to be. We shouldn't have to be as resilient as we are, but we are resilient. And that means that we do have the tools for success in our relationships. Inherent to our queerness is embracing nuance. It's like a deep understanding and empathy, is being creative and imaginative and open to something new, to something different, different from the status quo and different from what we previously believed to be true. Inherent in queerness is community and learning and growing and loving. And these are the tools that are already within us and within our communities. So, in this, I may not be telling you anything that you don't already know, but I may be providing you with additional supports for the skills that you already do have. So, the keys to working through our relationship dynamics through the perinatal period are listed here: communication, self advocacy, education, which you're doing right now, attending this talk, and community. So I'm going to spend like a good amount of time on this slide as we're talking about communication because, I am a therapist and communication is such a big part of therapy and it's a big part of relationships. Um, and so let's just start off with this little quote at the bottom. When it comes to communication, I like to say to do it early, do it often, and do it even when something seems obvious. What's obvious to you is not always obvious to everyone. So when in doubt, communicate. And with my psychology and therapy background, I thought it would be helpful to bring in some couples therapy skills from these different couples therapy modalities, and then also add in some queer considerations for all of us. And some of this you may have heard of before or engaged in some sort of a way. Feel free to, take screenshots of any of it if it feels useful to you. Starting off with EFT. or emotion focused therapy. Emotion focused therapy is so much about understanding your emotions and your partner's emotions. So the first bullet point there is emotional awareness. Emotional awareness often looks like, for a lot of people, finding your own therapist. Um, but it really means being able to just like understand your own shit, knowing what your triggers are and where they originated, especially so that you're able to catch yourself in real time and also maybe even explain to your partner why something feels a certain way to you. The next bullet point is reflective listening. Reflective listening is essentially listening to understand and not listening to respond or not listening to be defensive. So, an example would be if your partner says, I feel so alone with the nighttime wakings, a defensive response might be, well, I have to get up and go to work in the morning. A response that isn't defensive, but still isn't reflective listening might be like, okay, so tell me what you want me to do. You know, you're trying to help, right? You're trying to find a solution to the problem, but that's still not listening reflectively. It's listening to fix the problem. Reflective listening would be, wow, I didn't realize that you felt so alone with the nighttime waking. It's really just reflecting what the other person said with empathy and validation, which is the next slide or the next point. So yeah, once you've listened reflectively, an empathetic or a validating response can go a long way. That could look like, you know, that makes a lot of sense. I'd probably feel the same way if the roles were reversed. And then the next bullet point is identifying needs. Identifying your needs is important in many different conflicts, but I'm not simply talking about like the real time practical needs, even though that is important for sure. But it's also like identifying the deeper need. So in this like example of the partner who's doing all the nighttime wakings, you know, while that partner may definitely have like a real practical need of support and sleep, which like we should honor, another need might be, you know, I when I was a kid, I saw my mom parent alone while my other mom was preoccupied with work. And I just need to know that we're both in this, right? Like there is a deeper need there. Yes, there's the need for sleep, there's the need for support, but there's also this like need to not re-experience what this person's mom experienced when they were growing up. And then de-escalation is that last bullet point. Um, de-escalation is knowing when to slow down or to stop a conversation when it's getting too heated. For some relationships, this can look like having a safe word when tensions are rising. And then like and usually the safe word is like something completely silly because it then diffuses the situation. Um, but when the safe word is said, then that means that you can either pause or breathe, cool off for a set amount of time, or just like do a check-in to see how we're feeling in this moment. So that's kind of like the EFT techniques for sort of conflict resolution and communication. Um, Gottman has some similar techniques and includes strategies like being thoughtful with how you bring up certain conversations. Something that I usually say to clients is to strike when the iron is cold, as opposed to, most people say strike when the iron is hot. And by that, I mean, don't bring up a heated topic in the middle of an already heated argument or when you're feeling especially activated, right? Like choosing the right moment to bring up a potentially sensitive topic. Um, and then another thing is, needs over blame. So focusing on your own needs with I statements, like, I feel alone doing all the night wakings, as opposed to you never do any of the night wakings. It kind of shifts it from blaming to what your needs are. And then also being clear with what you need. Sometimes it's actually just as easy as saying, can you take half of the night waking so I can get some sleep? And it's as simple as that. And then this last bullet point to move towards and not against. Um, it's important to remember that you are partners. Your partner isn't the problem, it's you and your partner against the problem. Um, we, especially now, have so many enemies in this world, and we don't need to make enemies of our partners too. And then some queer considerations. One would be to not assume. Um, just because you have maybe similar genders or similar bodily experiences, or even if you've been pregnant before, don't assume that the other person understands your experience or that you understand theirs. And in fact, I'd go even further and say be open to not automatically knowing and be open to learning. And then, it's great that I'm like sharing some of these like couples therapy techniques. And I think that a lot of us have learned a lot of like really useful language within like our different therapies. But the danger of knowing some of this is that we might veer into pathologizing each other. And so it's important to also remember that we're each other's partners and not their therapists. And then some of the most important pieces, in my opinion, are to be able to acknowledge the discomfort in the changing dynamic and also allow yourself some space to grieve it. Um, Pregnancy and birth and babies, these are all joyful things, but there's also grief here too. There really always is. Um, in my own work as a perinatal therapist, I see the perinatal work as grief work. There's like always grief that's inherent in it because there's so much change. It's a time of pretty extreme transition. And with change often does come grief. Um, and it's important to kind of realize that maybe your partner isn't the person to support you in that grief for whatever reason, but there needs to be some sort of outlet or some sort of support or a ritual or something for each person in the relationship to do that, to, go through the process of working through and processing their grief. And then we're moving kind of into self advocacy, and I'll also add like partner advocacy as well into this. The National Association to Advance Black Births created what they call a Black Birthing Bill of Rights. And I looked over it and I kind of adapted it to create a queer birthing Bill of Rights. So this is like this slide and the next slide have some of them. This is another thing that maybe you can screenshot to use as your own affirmations and reminders for yourself as you start to navigate the reproductive and healthcare system, just within your queer bodies and within your queer relationships. I'll quickly read through some of these. And they're really just what you have the right to, right? You have the right to receive care from your providers that understand your queer experience, to receive support from a queer doula, birth companion, or other professional, to choose the family or chosen family that are present during pregnancy, birth, and postpartum, to access an independent perinatal advocate to address any concern, to choose your care providers and change your providers or birth settings at any point, to incorporate any spiritual or cultural practices or traditions into your care and into your birthing experience, to receive care that is free from homophobia, transphobia, biphobia, or obstetric violence, to access remedies if you're mistreated, neglected, discriminated against, or violated in any way, to make medical decisions for your baby and have uninterrupted time with your baby. You have the right to healthcare providers who listen to you, believe you, and acknowledge that your experiences are valid. You have the right to have your humanity recognized and acknowledged. You have the right to be treated with dignity and respect, to make an informed decision about how to nourish your child and to have your choice supported, to receive accurate information that will allow you to give informed consent or refusal. You have the right to providers that use the requested labels for your body parts, and providers that acknowledge your gender and use correct pronouns. You have the right to receive individualized postpartum care that supports and nurtures your physical and emotional and mental well-being. To receive queer-centered mental health care. To decline or say no to medical interventions or certain providers. To receive support in accessing care. To have your partner or partners included in your care. You deserve care, and you have the right to care that acknowledges, respects, and honors your queer and or trans identity. You have the right to care that meets your needs, regardless of body size, presentation, expression, and ability. And you have the right to choose when and how you become pregnant or become a parent. And then, last but certainly not least, there's community. It can't be up to just a partner to meet all of your perinatal support needs. Everyone says that it takes a village to raise a child, but I think that we, especially as queer folks, know that it actually takes a village to get pregnant. It takes a village to stay pregnant, to give birth, to feed a baby, to care for the postpartum person, and it takes a village to nurture a relationship. We are nothing without our community. So one of my biggest recommendations is that even ahead of trying to conceive or ahead of giving birth, ahead of the postpartum experience, really set yourself up with a community that you feel safe with. So that means starting to look for providers or groups or what have you that kind of like meet your needs and align with you and your values and who you are individually and as a couple. So here, there's just like some examples on the slide. Finding doulas, childbirth education, or prenatal groups that are in alignment with who you are. Finding OBs and midwives or lactation specialists, pediatricians even, newborn care specialists, folks that you may need in the future that align with who you are. Sometimes that looks like going to them with a list of questions to really just kind of like vet them. Before I had my baby, I went to several different pediatricians with a list. And a lot of them included, things like what would your stance be, or what would your take be if I came to you and said that my kid is thinking about transitioning, right? Like, or asking them what they know of, or like how they feel about working with a Black postpartum person, or what they know about Black maternal mortality, like things that are really important to who I am and my identity and my family. I brought that to the pediatrician, and like based on how the pediatricians answered, that's how I made my selection. When it comes to like body workers, like massage therapists and chiropractors, pelvic floor physical therapists and acupuncturists, finding folks that also understand you and your body and where your comfort lies. Finding folks that are trauma informed is really important because you never know who you're going to need in pregnancy and in postpartum. So it's good to kind of do that research ahead of time. Making sure that you have a psychotherapist, either individually or relationship therapists, who again are in alignment with who you are, with your identities, but also that are really well versed in the perinatal period. There is a difference, right? Like not all therapists and not all psychologists or other mental health counselors learn about the perinatal period. It's like not part of like our grad school curriculum. Those of us who want to specialize in perinatal work do extra work and extra training and education in that. So it could be helpful to find someone who specifically focuses on this specific time period. They have a better understanding of what you're going through. And then, of course, chosen family and blood family, really being able to lean on them, both parents and non-parents, right? a lot of times the friends and community members that are child free are the best supports. There are lots of people who specifically choose to be child free so that they can be more available to their friends and community members who do have kids. So this is a time to really lean on those supports. And then having group support is really important. Yes, in pregnancy, but especially in postpartum. I mean, a lot of you are already doing this by being a part of the Pregnant Together community. Um, but having folks that are in a similar kind of like life stage and phase as you is really important. I think that maybe some of you can have like already started to like realize and maybe have needed to navigate this, but you can maybe need to like find a balance between or like have to navigate feeling this like comparison with other people versus like feeling validated by other people. I think that that's something that happens a lot of times within groups and group settings, especially when, yes, you're having like a very similar experience, but then within that similar experience, there's so much like variance. So that's something to keep in mind. But it can be really, really healing and validating to be able to have people around you who are going through a similar experience, such as pregnancy and postpartum. So having that group support can be really, really important. And then with that, I would love to open us up to a little bit of discussion. Um, this is kind of the time we've got a little over 10 minutes left. This is a time for folks to just like kind of unmute and talk about maybe like what resonated so far, what kind of stood out to you, what you're thinking about, what maybe you're unsure about. I'd love for this to be more of like a communal discussion from this point. Um, and if folks feel like they might want to continue this conversation with me, like offline in any sort of a way, then feel free to reach out to me either, on my website, which is here, and that's where you'll find that PMADS checklist. You can email me here or find me on Instagram.
Good.
Um, but I'm
Thank you, Dr. Zann. That was so awesome.